please welcome to the stage Dagmar, Dr. Pandey, and Dr. Christenson. Thank you.
Hello, good morning, good morning. Please sit down and join us in talking about how to improve heart failure care. As Jonathan said, my name is Dagmar Schumacher. I'm the scientific partner for cardiometabolism within the Roche US Diagnostics organization. And I'm joined today by two experts who will discuss the strong HF and its implications, both from the laboratorian and the cardiology perspective. And I will first hand it over to them to let them introduce themselves.
Hello, everyone, and thank you for this opportunity to be part of this Idea Lab session. My name is Dr. Ambarish Pandey. I'm a cardiologist and associate professor of internal medicine at UT Southwestern Medical Center in Dallas, and excited to be here.
My name is Rob Christenson. Thank you very much for having us at this session today. I'm professor of pathology at the University of Maryland School of Medicine, and where clinically I run the core laboratories at the University of Maryland Medical Center. Thank you.
Thank you both for joining me. Maybe to give us some background and set the stage a bit, Dr. Christenson, can you give us a perspective how heart failure care has evolved over the past 2 decades? And from your perspective as a lab director, can you discuss the role of the cardiac biomarker and its value beyond heart failure diagnosis?
Well, great. I'm very happy to do that. You know, it's almost exactly 20 years to the day when NT-proBNP became available for use. Prior to that, we really had no biomarkers to assist cardiologists in making decisions about heart failure in patients. So, you know, over all these years, the biomarker has really remained the same. We've worked very hard to keep it rock solid as far as the same characteristics and so on. On the other hand, the field of cardiology has evolved tremendously, and we'll hear a bit about that in a few minutes. You know, NT-proBNP is really a surrogate for wall tension and for hemodynamic stress. And heart failure being a big cause of wall tension and hemodynamic stress, it's not surprising that virtually all patients with heart failure have increases in this biomarker. But it's also very important to remember that not all patients with an increased NT-proBNP have heart failure. There are many other causes for hemodynamic stress and for wall tension increases besides heart failure. And that's where our cardiology colleagues certainly have the job of sorting that out. So because the sensitivity of the biomarker of NT-proBNP is so great, it's a fabulous rule out for heart failure. So if the values are very low, then the chances of it being heart failure as the cause for the patient's symptoms are really very low. Even though it's not a terrifically specific marker, there are other causes, lung disease, et cetera, that can increase NT-proBNP. It still is a very good, its positive value is also very useful for clinicians to use. So that was how the biomarker got its name, was as a diagnostic tool for heart failure. But you know, it has evolved substantially. Just to mention a few applications, one would be risk stratification. The higher the value of NT-proBNP, the greater that patient's risk goes. And also as that was useful for management. And now we're moving into an era where actually NT-proBNP levels may help guide the therapy that patients receive from our cardiology colleagues. So, Dagmar?
Thank you so much, Dr. Christenson. Maybe I hand it over to you, Dr. Pandey. Do you have anything to add as a cardiologist?
Yes, I think it's been fascinating to watch the journey of NT-proBNP as a molecule of interest for cardiologists such as myself. And I've been practicing for a decade and doing research with biomarkers for a decade now. And it started almost 2 decades ago as a biomarker to diagnose heart failure in the ED, and the journey has been nothing short of fascinating to today when we use NT-proBNP in a lot of domains of care, ranging from still diagnosing heart failure when we are encountering a patient with shortness of breath to using it for risk prediction and identifying when the patient is ready to go home in terms of discharge levels. And then in the post-discharge outpatient setting, using it to inform our care and assess stability of heart failure in these patients. And most recently, now we are even going a step further and using this biomarker to identify individuals who may have asymptomatic heart failure or who may be at risk of developing heart failure. So it's just been amazing how the same molecule has almost percolated through every stage of the disease epidemiology and remains just as informative for care of these patients with different stages of this disease.
Thank you so much. And then also questions for you, Dr. Pandey. Let's briefly put heart failure into perspective. Can you speak to the prevalence of heart failure in the United States and the burden on the healthcare system? And then also, what is the prognosis for those diagnosed with heart failure?
Yeah, I think that's a great question, and reason why we are here. Heart failure is very prevalent among patients and in the general population, and it's the most common cause of hospitalization among older adults. The overall prevalence of heart failure currently is around, I think, 6.7 million adults over age of 21 have this condition, and it is expected to rise to 8.5 million by 2030. So the burden is only going to increase, and it is important because we see a lot of heart failure hospitalizations in our health system with over 900,000 cases of heart failure hospitalizations per year. And this is not a simple disease. It is associated with a lot of morbidity and mortality burden. The risk of death at 5 years post-diagnosis in patients with heart failure is in excess of 80% right now, and some data that is coming out from Get With The Guidelines Heart Failure Registry shows that. And the readmission rate is also very high, with around 20% patients who get hospitalized have a readmission event within 30 days of discharge. So 1 in 5 get readmitted within 30 days, and almost 50% get readmitted in a year. And all this adds up to a very high healthcare cost, where currently we're spending over $40 billion on care of patients with heart failure, and this number is only going to increase, and it is anticipated that it may increase by over 60% in the next few years. So we are talking about a condition that is very prevalent, very morbid, and has a high healthcare cost burden. So we can use all the help we can get in managing these patients.
Thank you so much. And now if we turn towards the impact of the STRONG-HF trial, can you tell us more about the recent results of STRONG-HF and how it is different from the current standard of care in heart failure? And then also, how does this have the potential to impact how heart failure is treated and ultimately impact the outcomes of people living with heart failure?
Yeah, I think that's a very important topic of discussion today. I believe STRONG-HF is one of the most important studies that was done in the recent times for management of heart failure. And there are some pillars of heart failure management that exist, which we refer to as guideline-directed medical therapy. This includes medications such as ACE inhibitors, or more recently, angiotensin receptor neprilysin inhibitor. We have beta blockers, mineralocorticoid receptor antagonists, and more recently, we have got SGLT2 inhibitors. So there has been a lot of data that these medications work, and they reduce the risk of heart failure hospitalization and mortality if they are used. The challenge has always been with their usage, and some data from the US heart failure registries have shown that less than 1% of patients who have heart failure are on actually the guideline recommended target doses of these medications. So there has been a big implementation gap in use of these guideline recommended medical therapy, and this is the gap that STRONG-HF trial addressed. Basically, it was a randomized control trial across multiple centers that evaluated a protocol-driven approach of rapid up-titration of guideline-directed medical therapy among patients at discharge from heart failure hospitalization, followed by close monitoring with clinic visits and NT-proBNP testing as a strategy to augment the clinical care. And what they saw was that in the intensive treatment arm, patients were discharged and they were up-titrated to guideline recommended target doses of these evidence-based therapies within 2 weeks, and then they had close monitoring that was informed by regular assessments of NT-proBNP and clinic follow-ups for next 2 months. And the usual care arm was basically following the usual clinical practice at the specific centers. And the observation that was most remarkable was that the intensive treatment arm was able to get their patients on the guideline recommended target doses in more than 50 to 80% of cases. In contrast, the usual care arm, less than 5% patients actually got onto the target dose of these life-saving evidence-based medications. And NT-proBNP monitoring assisted in the up-titration and management of these medication in these patients post-discharge, and had a very informative role to play in how the management evolved during the outpatient follow-up. And not only that, we were able to reach the guideline recommended doses, we saw a marked difference in risk of heart failure hospitalization and mortality at 6-month follow-up with using the NT-proBNP guided intensive treatment approach, such that those patients who had an intensive up-titration of these therapies and monitoring had up to 34% lower risk of death and heart failure hospitalizations within 180 days of discharge. And this is a remarkable treatment effect that is, I think, comparable to any other therapy that exists for heart failure currently. So in a nutshell, I think STRONG-HF did show us that we need to get our patients on these evidence-based therapies faster, and we can get them on these therapies faster and safer if we monitor them and follow a protocol that utilizes the biomarker-driven approach to safely up-titrate these medications. And it highlights the need to implement similar strategies in the real world to get our patients on these therapies and reduce their burden of morbidity and mortality in the long run.
Thank you, Dr. Pandey, for this great summary. Now a question that I would like to ask both of you. How can providers and laboratorians work together when it comes now to employing biomarkers like NT-proBNP being used to improve heart failure outcomes for patients?
So to take a half a step back, thank you very much for that, that wonderful description. But you know what? We spend a lot of time as laboratorians trying to think of how we can demonstrate value of the lab to clinicians. And I think it's so, this is such a great example of the use of these, the application of these biomarkers by clinicians to really improve the outcomes of patients. So our job really is to provide these measurements in a very timely fashion so that folks like Dr. Pandey can utilize them to improve the outcomes of these patients. And it's amazing that it went from 1% guideline of the patients who are really getting the guideline recommended therapy to, I mean, what is it? What was it at the end?
Up to 50% were on evidence-based ACE inhibitors and beta blockers, and up to 80% were on the mineralocorticoid receptor antagonists.
So it was not a new drug, it was just application of the drugs in the right way, and the biomarker really assisted in doing that. So I think that's a really important point for all the laboratorians to remember. That's a way we can show values, to work together with the cardiologists to make sure that they get the values when they need them to make these decisions. So I think it's a terrific opportunity for us.
Thank you. Anything from your side as a cardiologist?
Yes, I think these biomarkers like NT-proBNP are of tremendous use for us in the clinical setting in helping us monitor the disease status, the disease severity, and the direction in which the patient's clinical condition is headed. And sometimes we rely too much on patients reporting symptoms, and by that time it's already too late. And I think the biomarker-driven approach is really helpful in identifying patients who can be safely up-titrated on these evidence-based therapies in a quick manner, and can also help us identify those who are headed in the wrong direction and may need a different kind of approach and a slower up-titration approach. And this is where NT-proBNP was so useful in a protocol like STRONG-HF, where not all patients with heart failure are the same, and we need to identify who we can be more aggressive with GDMT up-titration and who we need to be more cautious. And NT-proBNP was able to inform that and help with this tailored, personalized approach to guideline-directed medical therapy.
Well, it's very interesting that they actually stopped the trial, right? The intervention was so successful, just to make sure that the guidelines were being followed, and the results so dramatic that the safety committee stopped the trial. So again, a great testimonial about working together between disciplines to help improve outcomes.
Thank you so much. And of course, we're hoping that laboratorians continue to work with cardiologists
Absolutely.
to make this basically evidence-based implication reality in the future. Now, as we come to the end of our time together, can you share both, maybe in one sentence, what do you see as the future of heart failure diagnostics and management? Let's start with Dr. Christenson first, maybe.
So I think it's all about early detection. I think we heard about asymptomatic patients and recognizing that they are at increased risk, and then getting those therapies started earlier that are known to improve outcomes. So in one sentence, I would be that let's help with the early diagnosis of this such a burdensome diagnosis.
Excellent.
Yeah, I would add that I think post-COVID, we have learned a lot about how we can take care of patients at their home and how we can implement a lot of their management at home without waiting for them to be seen in the clinic in 6 months or 3 months. And for heart failure, since the burden of the disease is increasing so much and the number of heart failure doctors is not increasing at the same rate, we're going to have long wait times in clinics for these patients to be seen again. So I think at some stage, we need to get on with the technology and start doing what STRONG-HF did with home monitoring and testing for NT-proBNP and other vital signs and biomarkers at home, and leveraging that data to safely up-titrate these medications while the patients are in the comforts of their home and not wait for them to come to the clinic every 3 months, because we lose precious time when we are doing that. And this era, with the evolution of telemedicine and remote monitoring programs, I think there is a strong need to incorporate a STRONG-HF-like protocol in a home-based care manner.
You know, that's such an important point, because then you can intervene before there's some event that happens that brings them to the hospital. You can recognize that something's going on earlier, but you really need the tools, the weight of the patient, the biomarkers to impact that.
And that's exactly right. And I think biomarkers can tell us a lot about patients' disease. And I think if we can check it regularly in our patients during inpatient visit or whenever we are thinking about up-titrating their medications, it does give us a lot of information about the trajectory of their condition and helps us feel better when we are trying to make decisions like going up on their medications. And also it informs us if the patient is headed in the wrong direction and needs a different kind of approach towards their management.
So that clearly points to a need for maybe even a home measurement of NT-proBNP and other biomarkers.
Yes, definitely. If we can get that, I think that would be a major breakthrough in how we manage heart failure currently.
Thank you both so much for these insights. And I would like to open it up for maybe 1 or 2 questions from the audience.
Thank you very much. That was very, very informative. So touching base on your thoughts on the future of diagnostic testing in the home, you know, from a laboratory perspective, I'm a laboratorian, so, you know, administrative director and kind of trying to look at that and understand how. Do you have any thoughts on how that could be done in the future?
Well, I think we need to run the right trials to see exactly how to do that. I mean, there are variables that patients can get themselves and then have a frequent contact, some way of getting that information back, maybe automated, interfaced, you know, maybe by use of our phones, whatever. So I think getting that information to the right people will really be the key thing.
Yeah, I think there are platforms that exist now that are doing such studies where we are monitoring patients at home using wearable devices and Apple Watches and I think home-based blood pressure monitoring. And I think there's different technology evolution that is happening pretty quickly. From biomarker standpoint, I think we still are limited in the sense that we have to send the blood work to a lab to get their NT-proBNP information. And I think that is still informative because there are approaches to do home-based testing where a phlebotomist can come and collect the blood and run it. But I think the real advancement in biomarker utilization will happen when we get a point-of-care testing at home. And we saw how technology evolved for COVID testing at home in the last couple of years. I'm sure that technology evolution will happen in cardiac biomarkers as well, and that will actually speed up the innovation that is needed to implement care of these patients using a home-based approach.
And as a laboratorian yourself, you know how important all the phases are, right? That pre-analytical, having it so that anybody can can get the right sample to measure, then doing the measurement, we're using a device, and then how to report that. So all three phases of testing will have to be thought about. But sounds like there's progress being made now, so that's good news.
Thank you, doctors.
I think
Any other questions for Dr. Pandey and Dr. Christenson? All right. All right. Thank you, Dagmar. Thank you, Dr. Pandey. Thank you, Dr. Christenson. Let's give them a round of applause, everyone. Thank you very much for joining us today.
Well, great. Thank you very much.